Hello and welcome to my presentation with oral defense. Today I'll be discussing the pharmacokinetics of N-acetylcysteine in patients with advanced cerebral adrenoleukodystrophy who are undergoing hematopoietic stem cell transplantation. To start off, I'd like to go into some of the background on my topic. ALD is one of the most common perioxysomal disorders and affects approximately 1 in 17,000 births each year. ALD is caused by mutations in the ABCD1 gene, which encodes for the protein ALDP. ALDP is involved in the transmembrane transport of very long-chain fatty acids, and a defect in ALDP causes a buildup of very long-chain fatty acids in plasma and in tissues including white matter regions of the brain, the spinal cord, and the adrenal cortex. The buildup of very long-chain fatty acids causes an increase in oxidative stress and oxidative damage, which leads to inflammation in the cells, causing demyelination, which is the breakdown of the myelin sheath. This oxidative stress is also partly due to the reduced glutathione concentrations that are commonly reported in ALD patients. Glutathione, or GSH, is a non-enzymatic scavenger of free radical and is an important component of the antioxidant defense system. Disturbances in the homeostasis of glutathione can lead to increased susceptibility toward oxidative stress, contributing to the pathogenesis of diseases like ALD. Of the several ALD phenotypes, the cerebral adrenoleukodystrophy is the most severe, resulting in rapid neurological deterioration and early death. Several studies have shown that despite the significant mortality risk, hematopoietic stem cell transplantation, or HST, remains the only therapeutic intervention that can arrest the progression of CALD. However, it does not reverse the mutation. Previous studies like Raymond et al. Have documented favorable outcomes when HST is performed early in the course of the disease, with better survival post-transplantation when performed in pre-symptomatic boys. However, HSCT is not recommended in individuals with advanced stages, who are in the advanced stage of the disease, due to the lower survival rates post-HSCT. Currently, however, the University of Minnesota is investigating the use of the antioxidant N-acetylcysteine, or NAC, as a therapeutic strategy to change this fatal disease, CALD, to a condition that is treatable with HSCT. HSCT has been associated with the rapid advancement of the disease due to the intense chemotherapy to ablate the bone marrow. This treatment leads to an increase in oxidative stress and damage, which often leads to death. Thus, to alleviate both the oxidative stress and damage associated with both the treatment and the disease, current studies have been N-acetylcysteine is currently being investigated as a therapeutic strategy due to its numerous mechanisms of action, which include scavenging free radicals, facilitating GSH biosynthesis via providing the rate-limiting molecule cysteine when body breaks down NAC, as well as reducing the damage inflicted by reactive oxygen species. Since CLD patients have been reported with depleted or reduced levels of glutathione and an increase in reactive oxygen species, a study conducted by the University of Minnesota, Toller et al., had investigated the use of NAC as an adjunctive therapy with HSCT for patients with advanced CALD. The results from the study support the fact that NAC does mitigate the oxidative stress and damage associated with both the disease and the treatment by increasing glutathione levels as well as attacking the reactive oxygen species. However, this study and many other studies have mentioned that the optimal dose and timing of NAC has yet to be established. As a result, through my study, I attempt to analyze how the concentrations of intravenously administered NAC, its downstream metabolite cysteine, and glutathione change over the course of HSCT, so far lacking in scientific research. Prior research and understanding of NAC, cysteine, glutathione has led to my initial hypothesis that an increase in NAC, the infusion of NAC will lead to an increase of cysteine as the body breaks NAC down, which will then lead to an increase in glutathione, as cysteine is a direct precursor to glutathione synthesis. Now I'll briefly be discussing the methods of my research project. So in order to analyze how the concentrations of intravenously administered NAC, and its downstream metabolite cysteine and glutathione change over the course of HSCT, 11 patients were selected for this analysis. These patients were diagnosed with advanced CLD and were undergoing HSCT with NAC infusions at the University of Minnesota. The 11 patients were all given NAC as an adjunctive therapy during this treatment. Then, blood samples were collected for each of the patients at the 3 different stages during HSCT. The 3 stages include -7 days prior to HSCT, which are classified as AUC1, 7 days after HSCT, which are classified as AUC2, and 21 days after HSCT, which are classified as AUC3. During each of these stages, blood samples were collected at 0, 0.5, 1, 2, 5, 8, and 11 hours post-NAC infusion. Once the blood samples were drawn from the patients, the plasma in the blood samples was separated from the red blood cells, and total concentrations of NAC, cysteine, and glutathione were measured using high-performance liquid chromatography mass spectrometry. Once the concentrations of NAC, cysteine, and glutathione were measured and collected, this data was stored in Excel. Then, I used descriptive statistical analysis to generate the average concentration of NAC, cysteine, and glutathione during the 3 stages of HSCT for this entire cohort of 11 patients. This analysis consisted of several steps. The first step was to separate the data into 3 groups. One group consisted of all the NAC concentrations collected during the 3 different stages for the 11 patients. One group consisted of the cysteine concentrations, and one group consisted of the glutathione concentrations. Once the data was separated into 3 groups, the next step was to calculate the average concentration, standard deviation, and standard error for each compound at each time point during the 3 different stages. Using the results from the statistical analysis, the last step was to plot the graphs for each compound and analyze how the concentrations changed over the course of the treatment. Now I'll be discussing the results from my research project. Here on the right side, we can see the table with the values of the average concentrations of NAC at each time point during each stage of the transplant, AUC1, AUC2, and AUC3. On the left, we see the graph with the values plotted on them with the average concentration on the y-axis and the time in hours in the x-axis. Each of the 3 curves on the graph represent the 3 different stages of HSCT, the blue being AUC1, the orange being AUC2, and the gray being AUC3. By analyzing this figure, we can make several interpretations on how the concentration of NAC changed during HSCT. Here we can see that there's a similar pattern between AUC1, AUC2, and AUC3. This result suggests that the stage of HSCT treatment has little or no effect on when the peak average concentration of NAC is achieved and how the drug is metabolized. However, it is important to note that as the treatment progresses, the highest average NAC concentration absorbed gradually decreases, and this suggests that the patient is breaking down and absorbing NAC, absorbing less NAC as the treatment progresses, which could potentially mean that the treatment has been successful and the body is requiring less antioxidants to reduce the oxidative stress and damage. Moving on, we will be now looking at the average cysteine concentrations during this treatment. Here we can see that there is no strong pattern between how the concentrations of cysteine change over the course of treatment. And we can also see that the average concentration for the 3 different stages is fairly constant. This could suggest that HSCT had very little effect on the average concentration. Additionally, another possible explanation for why the concentrations of cysteine were constant is due to the immediate turnaround rate of cysteine. Usually when NAC is metabolized, we expect an increase in cysteine as the body is breaking down the drug. However, based on these results, however, we can see that the cysteine with the increased cysteine from the NAC is immediately being converted into glutathione combining with other cysteine to form cysteine, or attaching to different proteins within the body. Collecting blood samples more frequently throughout each stage of the transplant may potentially show how the NAC infusions are influencing cysteine concentrations. Moving on to the average GSH concentrations. Here we see that there's no tight pattern or strong correlation between the three different stages of transplant, and this could potentially mean that the transplant is indeed affecting the way glutathione is being produced. Since HSCT is associated with the increase in oxidative stress, it could explain why the concentration for AUC1 was drastically higher than AUC2 and AUC3, as the body is consuming more glutathione to reduce the oxidative stress during the later stages of treatment. Here it's important to note that the concentrations for GSH were quite low because we used plasma as the matrix to measure GSH, and thus the results are not completely representative of how the glutathione concentrations change over the course of HSCT. Now I'll be going on to the discussion of my results. So analyzing and making interpretations for cysteine and glutathione were extremely difficult in this project since both of these molecules are endogenous. As a result, other factors apart from NAC and HSCT could have affected how these concentrations changed throughout the treatment. The results from the study have rejected the initial hypothesis since the peak concentration for both cysteine and NAC occurred immediately or right after the NAC infusion, while the peak glutathione concentration did not occur until several hours after the NAC infusion. From the results, it is safe to conclude that there is no strong correlation between how NAC, cysteine, or glutathione concentrations change during the HSCT treatment, and that there are other confounding variables affecting these concentrations. Now I'll be going on to the conclusion where I'll be talking about the limitations and implications of my research project. The study had several limitations that need to be addressed in further research. The first limitation is the small number of participants. Each participant constitutes a large portion of the average concentration, and thus, as a result, one person's concentration may deviate significantly from the others, and thus skewing the entire data. Increasing the sample size can lower the amount of variability in the average concentrations of NAC, cysteine, and glutathione, which is something that future research should address. Additionally, blood samples for the 11 patients were not collected 11 hours after NAC infusion during both AUC2 and AUC3, and thus it was not possible to determine how the concentrations of NAC, cysteine, and glutathione changed at that time point. There are also several other instances where the blood samples were not collected for an individual patient due to some other clinical or logistical reason that are beyond the scope of this project. Another limitation in this study was that several data had to be excluded due to the hemolysis of blood samples. When this occurred, the plasma sample was diluted with the contents of the red blood cells, which could potentially skew the data, and we could see inaccurate concentrations for the three compounds. As a result, if the measured concentration from the samples that underwent hemolysis didn't match the rest of the data was excluded from the study. Furthermore, another limitation of the study is the measurement of glutathione in plasma rather than in red blood cells, as higher concentrations of glutathione are found in red blood cells. Since the concentration of glutathione were quite low in this study, it was difficult to make interpretations as to how NAC or the treatment HSCT was affecting the concentrations. Lastly, a more thorough and in-depth statistical analysis for small sample sizes will be needed to support or refute the results from this study. Now I'll be moving on to the implications of my research project. The results from the study have numerous implications in the research surrounding NAC, CALD, and HSCT. This study is one of the first few steps towards finding the optimal dose and timing of NAC during the HSCT treatment and improving the standard of care for patients with for advanced CALD. Currently, advanced CALD patients are being administered large amounts of NAC and are being hospitalized for up to 100 days post HSCT, which is quite exhausting and extensive for these patients. The results and interpretations from this study can allow future researchers to understand how the concentrations of NAC, cysteine, and glutathione are changing throughout the HSCT treatment, which will eventually lead them to finding the optimal dose and timing of the NAC regimen, such as how much, how often, and how long it should be administered to the patient. In this study, the major gap was the inability to interpret the results from the statistical analysis performed on glutathione due to low concentrations and high variability. Thus, future research should look into and address this gap by using red blood cells as the matrix to measure glutathione concentrations. Lastly, future researchers should address the several limitations I indicated previously to produce better results and make better interpretations on how the concentrations of the three compounds NAC, cysteine, and glutathione change throughout the course of HSCT.
Nice job, Anthony. So as you know, this is the end of the presentation part with oral defense questions. I'll ask you one of each of the questions you prepared for from the categories: the research process, your depth of understanding, and reflection on the inquiry process. And the first question I have for you is difficult because I think you addressed it quite well in the presentation. Most of these in this category you've addressed, so you may have to reiterate your response, but I'll just ask you to tell me a little bit more about how your findings provide direction for future research in the field, maybe some specifics or what you would do next.
Yeah. So in the future, the goal of this research in the field is to determine the optimal dose and timing of NAC. Since patients currently are being administered large amount of NAC, they're being hospitalized for up to 100 days post HSCT. So by understanding how these concentrations can change, researchers can find this optimal dose and timing to reduce the amount of time the patients spend in the hospital, since dose finding studies usually reveal efficacy at higher doses or higher efficacy at higher doses or equal efficacy at lower doses.
Thank you. Then my next question is, how did you determine which results generated by your research method were the most important in informing your new understanding?
So I looked at the results that were different from what I initially hypothesized or assumed to be. For example, in the NAC results, we saw that the pattern for the three different stages were similar, and that is what I initially predicted or hypothesized. However, for the cysteine and glutathione concentrations, the results were completely different from what I initially thought they would be, and so these results have led to me asking more questions as to how or why did we observe the pattern that we observed, and what are some potential reasons for why this occurred.
Excellent. And then my last question for you is, what was the most important research skill that you developed as a result of this process, and how might you apply it to future endeavors?
So the most important research skill I found was to never give up and be open to different ideas and learning different skills during the research process. For example, prior to this project, I had no experience working with Excel, and so when I initially started, it was difficult for me to calculate the standard deviation, average, and standard error using the different formulas in Excel, as well as when I plotted the graphs. I had a difficult time of using the different tools in Excel to create a graph that could show my results. And so being open to open to spending the time to learn these different skills had really helped me in this research process.
Excellent. Well, Anthony, that finalizes the formal part of your presentation with oral defense. Congratulations.